Hello, my name is James Carr and I am a radiologist at Northwestern University in Chicago, and I will be talking to you today describing the disruption of radiology departments during the ongoing COVID pandemic, and particularly giving some example from my own department. This is my disclosure slide. So as background information, COVID-19 has caused over 27 million cases around the world to date. And this has resulted in an increased burden on the resources of our healthcare systems. One consequence of the COVID pandemic is that non-COVID patients with other diseases may not have received the medical care that they needed. And this has potentially been delayed or in some cases overlooked. Additionally, many COVID patients have been shown to develop non-respiratory complications, including cardiovascular manifestations. And this slide here shows you the case number from the United States, indicating the second surge here that occurred in midsummer after the early surge in the spring. So in my own department, we followed a number of general principles when it came to governing the radiology response to the COVID-19 pandemic. The first principle was to provide outstanding clinical service. So we wanted to make sure we provided rapid interpretations, high quality imaging, that it was available to all referring physicians. We also developed a prioritization scheme for all of our clinical studies. Also, we wanted to ensure the safety of our staff and patients by making sure that all safety measures were put in place, including having adequate protective equipment at hand, and also making sure that patients were screened in advance just to make sure the staff knew if there were COVID positive patients coming into the department. We developed operations teams comprised of physicians, staff, nurses, technologists that met daily and discussed any issues that arose around the department, any concerns with regard to safety, any issues with workflow. And also we made sure that any institutional mandates were rapidly communicated to these operations teams meetings so that they could be rapidly implemented at the departmental level. And then finally, we strove to maintain open, regular communication with the staff and the trainees and the physicians. And this came in the form of regular email communications, social media, webinars, etc. We also held town hall meetings at which the staff could answer any questions if they arose. From a specific perspective, when it came to our clinical operations, there were a few points that we did focus on that I wanted to highlight. The first thing we did was provide workstations, that's remote workstations or home workstations, for all of our diagnostic radiologists. And these were all located at home. Some of these were located in physician offices, and this allowed them to provide primarily off-site coverage, but also a mixture of on-site and off-site coverage. The initial priority was to make sure that we kept our physicians, diagnostic radiologists, healthy in the case of a rapid spread of the virus, so that it would prevent them from becoming infected, and making sure that they could continue providing medical care and rapid reads. It also provided a secondary benefit of being able to cover the radiology service almost 24/7 in flexible shifts. So while this was not maybe previously easy because most people were coming on site to the hospital, this was made much more practical when physicians were able to work from home. For the in-house services, i.e. the patient-facing services in interventional radiology, breast imaging, neurointerventional radiology, the services were divided into teams, and those teams did not overlap to make sure that they did not cross-infect each other. We also developed a clinical case optimization and prioritization scheme so that urgent studies were done and non-urgent studies could be deferred. And we did this by using triaging pager manned by physicians. We had specific COVID workflows such that certain scanners were dedicated to COVID patients. We minimized our turnaround times for reports, and we also created new services such as an IR line placement service for COVID patients in the ICU. We also wanted to provide services that were consistent throughout the system of hospitals in the enterprise. So one example was the reporting of CT chests where COVID was suspected. So we wanted to make sure that the wording and nomenclature in the CT reports, for example, was consistent with the guidelines and that there was no room for misinterpretation. So this meant that all radiologists, no matter what hospital they were practicing in within the Northwestern Medicine enterprise, all gave similar reports and recommendations. And this information was transferred out through system-wide council meetings of physicians and staff. For those staff members that did not need to work full-time because of the reduction in volume of cases, they all participated in the labour pool. This meant that they were deployed to other regions of the hospital, either on the floors, in the ICUs, in the emergency departments, manning the entrances to the hospital, manning the COVID hotline, etc. And at one point, the radiology staff actually made up the largest proportion of members of this labour pool. Nobody was furloughed or laid off during this process because all of the staff members were used for multiple purposes throughout the hospital. From a research perspective, all of the research staff, faculty, and students immediately began to work remotely, and all of our core imaging centres shut down. So there was no inpatient or directly facing patient scanning performed. Also, all open studies were closed to accrual for new patients. With regard to education, all of our learning was switched to virtual online learning. So all of the didactic lectures for our trainees became virtual. The number of our residents in-house was significantly reduced, and they were given remote laptops to be able to view cases virtually. The only area which was directly staffed on site was the emergency department. This was prioritized. Fellows were divided into teams similar to the patient-facing teams on the attending side. As I mentioned, laptops were provided for remote working or learning. Virtual learning electives were created for the medical students, so they didn't have to come on site. And then we established virtual grand rounds and webinars system-wide on a regular basis, typically about every week. So what was the general impact on radiology? Well, first of all, because of the triaging of cases, there was a marked reduction in clinical volume. There was also a significant shift to off-campus work. In fact, during the depth of the pandemic, we had no diagnostic radiologists or trainees on site apart from in the emergency department. Staff wellness became a concern. First of all, because staff were increasingly isolated, and like the general public, were also being exposed to the information from the media about the increasing severity of the pandemic. So there was increasing concerns for their own welfare and the welfare of their families. And finally, of course, because of the reduction in our imaging volume and overall volume of medical care, there was a financial impact to the department. With regard to specific areas, because of the home workstations and the deployment of these workstations at home, it provided much greater flexibility in clinical coverage and allowed our clinical service to move to more of a shift type work, so you could cover more 24/7 or into the evenings. Our research operations became much more productive, resulting in an increased numbers of research grant proposals and awards, as well as an increase in the output of publications. Also, we began to focus on novel areas of research, specifically focusing, for example, on some of the cardiovascular complications of COVID infection. With regard to education, there was a complete shift to virtual learning, so lectures, webinars, tutorials, etc. We introduced remote supervision of trainees. So, for example, all trainees were read out remotely by attendings using various online platforms such as Microsoft Teams or Zoom. And this brought up some additional challenges with regard to trainee interviewing. So how are we going to manage the upcoming interview season when we're in a completely virtual environment? And then finally, from an administrative perspective, all of our conferences and meetings became virtual. This was very efficient, but also introduced this other disadvantage of isolation and what's now known as Zoom fatigue, as people go from meeting to meeting online. There's been a number of publications produced recently on the impact on radiology in general. This publication describes the impact on education and illustrates some of the points I've talked about. So remote interpretation became very commonplace during COVID, both for trainees and attendings. There had to be training in COVID-19 CT interpretation. So what were the findings that were typical of COVID infection? Some of our trainees volunteered for redeployment to direct patient care roles in the labor pool. And then online reading, teleconferencing, virtual readers became very, very prominent. We also had to make sure that there was prompt and clear communication about the guidelines on infection control. So what would happen if a trainee, for example, became infected? What were the procedures that were put in place? And also what happens with trainees and also faculty who have significant childcare responsibilities? Can they come into work? What kind of allowances can be made for them? Some unanticipated consequences of this strategy are illustrated in this slide, where patients now, because of the increasing COVID pandemic and awareness, became afraid to come to the hospital emergency departments. And this resulted in an increased incidence of heart attacks in patients who chose to stay at home. And this is now well documented in the literature and is something that was unanticipated and is something that we cannot repeat should we have to respond to this COVID crisis again. This study, which was published online ahead of print, shows the declines in the imaging volumes in various different practice types. And this was data collected by a survey of 48 questions, which resulted in about 242 responses for a number of different type of imaging facilities. And you can see overall, in general, in all of these facilities, the volumes of imaging declined by as much as 64%. The decline was most prominent in the outpatient setting, as you'd expect. This also resulted in a reduction in the mean gross charges, as well as the collections of about 50%. So again, the reduction in clinical volume leads to consequence financial impact, which was pretty severe during the depth of the pandemic. In this publication, you can see that it illustrates the reduction in the imaging volume by modality. And you can see that nuclear medicine mammography were the most hit. Not unexpected with mammography because of screening mammography, but then CT and MR were less severely affected, particularly CT, because this was increasingly used to diagnose disease in patients with suspected respiratory infection due to COVID. This is a slide which shows the impact on our own radiology volumes at Northwestern. You can see this pretty much mirrors the data from the literature. We saw a pretty rapid decline in our total imaging volume around mid-March, went to a depth at around the beginning of April, and then slowly came back up to reach 100% in approximately June or early July. Again, similar to the published literature, mammography, as shown here, was the most hit and affected because of the screening nature of mammography, as was nuclear medicine, whereas the graph on the right shows that CT in particular was least affected. And again, for the reasons I mentioned, because CT was increasingly used during the COVID pandemic to diagnose respiratory illness. Similarly, the impact was most affected in the outpatient sphere. So the outpatient volume, in our experience, really was significantly impacted, whereas inpatients and the emergency department were less impacted. In fact, there was not much change in the emergency department volume of imaging studies overall. So what about the reactivation of radiology services? So the ACR have produced a statement on the safe resumption of routine radiology care, and this is based on a number of guidelines here. So they emphasize that facilities need to have a comprehensive strategy for the safe resumption of radiology care, and this is based on local statistics, so how prevalent is the infection in your local community, state and institutional mandates, safety, so the availability of protective equipment, as well as what are the indications for the studies. Do you prioritize, for example, oncology studies over less urgent studies? Another principle was if the risk to the healthcare worker or patient is greater than the risk for delaying care, then the study should be delayed. This seems obvious. They also emphasized that appropriate safety measures should be in place, so screening of both patients and staff. There needed to be an adequate testing regimen in place, an infection control process, as well as adequate protective equipment. And then also each facility needed to determine an accurate risk-benefit analysis of postponing a test versus performing the test itself. With regard to our own experiences with reactivation, we reopened the schedule, again, similar to the way we closed it down. So we prioritized clinical cases. So those patients that had had their care deferred for a long period of time were prioritized. Oncology patients were prioritized. Acute vascular cases were prioritized. Patients were brought to our radiology facilities under certain conditions. So we needed to make sure that they were screened for potential COVID. They were adequately distanced. We had safety measures in place. This meant that we had to have extended hours of our imaging time, and off-site locations as well as weekend capacity was utilized for imaging. We prioritized patient and staff safety, so distancing and masking were an important component of this. We introduced touchless registration for patients, so this is so-called online registration via apps or on computer. And there still remains some specific concerns, specifically around sonography, for example, where sonographers had direct interface with the patients. We deployed a phased approach to bringing physicians back on campus. Not all physicians came back immediately. We gradually introduced physicians to be back on site. Education and trainees were brought back on site. The education continued to be virtual. We did schedule trainees on site, but there was still a mixture of remote service. And there was also a research reactivation plan put in place, which tended to lag the clinical plan, where staff came back on site and core facilities were opened up again. This is a recent study which shows a recommended workflow for reactivating radiology volumes. And in this study, they suggested a very much a staged approach where you would increase your volume in 20% increments. And if you reached any particular benchmarks that were adverse, it may result in you going back to the original level. So for example, if there was a new COVID-19 case in a healthcare worker, the number of hospital COVID cases increased, if the protective equipment became depleted, or there wasn't adequate vendor support for equipment, then that might cause you to go back to a prior stage. This is just an example of our own reactivation volume. This is an example from CT, and you can see that our volume really reactivated very rapidly. We were back up at over 100% of our original volume within a matter of weeks. And this was impressive, and this is with all of the safety measures in place. So what were some of the take-home points from our own experience of radiology? Well, the clinical radiology service can be flexibly provided through a mix of on-campus and off-campus coverage, and we saw that through the use of home workstations. Some innovative clinical practice initiatives will continue to grow, such as touchless registration, e-registration, a virtual hospital environment, telehealth or teleradiology. Virtual working will continue, as will virtual learning and conferencing, and will become more routine. But there will be persistent challenges and limitations. And one of these examples is childcare. Many of the schools are shut down. Childcare facilities have not reopened. So many of our staff and physicians have childcare responsibilities which preclude them from coming back on site. So it is important that we provide facilities remotely so that staff and physicians can work and also take care of their families. In summary, the initial imaging response to COVID focused on surge planning, resulting in a significant reduction in the imaging volume. Reactivation resulted in a rapid increase in the overall studies, very rapidly within a period of weeks. Other disease complications, example, cardiovascular complications, may have increased due to reprioritization of resources. And COVID has dramatically shifted how we practice radiology and medicine, possibly permanently. This slide is from the New York Times archive and shows a street in New York at the end of the flu pandemic of 1918. And you can see even back then, masking was recommended, but also at that time, the use of masks was variable. So it's interesting how times have not changed, and we can use the experience of 1918 as an example. Thank you for your attention.